Hello everybody, this is Dennis Stanley from Respiratory Sensei, and you may know me from LindseyJones. We're here today to talk about ventilator waveforms, a very nerdy subject, but I want to tell you that there's an awful lot of respiratory therapists who ignore ventilator waveforms, as do physicians and sometimes even ICU nurses. They don't really like to look at your ventilator anyway. But I also want to tell you that you can learn more about a patient or the ventilatory methods that you should be using by looking at ventilator graphics than you ever could by looking at numbers. So let's just take a deep dive. All right, with ventilator graphics, this is part of a two-part series. We're first going to talk about ventilator waveforms, which is slightly different than ventilator loops. And with ventilator loops, you can tell a lot about a patient. It'll change your care. It'll definitely change your game and improve your patient care. But it's a big subject, so we're going to split this up into two parts. Be sure to subscribe and like and ask for notifications so that you get that notification out when that second video comes out, and so that you can keep up with all of the very cool things that we're going to talk about on Respiratory Sensei. All right, so the first thing to know is that as a respiratory therapist, the word therapist actually means to theorize, which means you're also an advisor to those who are taking care of the patient, especially the doctor. And so one reason to understand ventilator graphics is so that you can understand the patient enough to go to the doctor and make recommendations in terms of ventilation changes that you can make, or changes on the ventilator with flow, volume, time, ID ratio, whatever. So you can make those changes and improve the patient's care. And then, of course, the second reason is obvious. You are caring for the patient and you want to improve the patient's care. So we're going to take a look at some of these ventilator graphics. Now, when it comes to ventilator graphics, know this: there are really three basic things that we're trying to track in the graph. And that is pressure, so we can take a look at a pressure waveform, and that helps us to understand certain things about how the patient's ventilating. But we can also take a look at volume, and we can also take a look at flow. With pressure, volume, and flow, we can look at everything. Today, first, we're going to start talking about looking at those on a graphic. But as you might know, when we look at a graph, we have to look at two axes. And so when we look at pressure, we mean pressure versus what, or volume versus what, or flow versus what. So the most common way to look at these things is to look at flow versus time, and pressure versus time, and volume versus time. So that's what we're going to look at first. Just going to look at these raw graphics. So let's take a peek at what we have. Okay, as you can see on the screen here, I have the three basic graphs that you could do. Remember, we talked about pressure, and the waveform will approximately look like that. And then, of course, we also have the flow versus time, and the graphic will generally look like that. And then there's the volume graphic, which looks about like that. I just want to show you that you can get graphics that look like a lot of different things. We won't talk about this now. We'll talk about it more in part 2, but we can also look not just in pressure versus time, but we could also look at pressure versus volume, or pressure versus flow, or flow versus time, or flow versus volume. You can look at any number of things, and we can tell certain things about the patient. But what we want to know about graphics is that there is a normal way in which that graphic waveform is supposed to look. And if it is deviating from normal, we should conclude one of two things. One, there's something wrong with the patient. I mean, there may be a disease process or changes that's happening that we need to be aware of so we can care for the patient in a different way. But the other thing that we might come to the conclusion is that we may need to change the ventilator. And it's not that we're ventilating the patient incorrectly, but we might be able to identify an opportunity to ventilate the patient in slightly different mode, or in a different way, with a different flow, volume, any number of parameters that we might be able to change. So that's what we're going to talk about in this video: what a normal graphic would look like, and what some problems would look like, and how you should address those. So let's first start off by looking at the pressure waveform. All right, so here we have a classic pressure waveform, and in reality, this is not exactly true. What you're probably going to see, and I'll explain this in a minute. Let me just get my little pen here. Generally, this waveform is going to come up and then just go straight down like this. But what you'll notice is that we have this little dip here, so we're going to label that as well. But let me just first start off by labeling the key parts of this graph, if I may. All right, and so the first thing you want to look at is we have this section right here where the graph starts off. You'll see this little green line. All right, when you look at that green line, be aware that that is the starting pressure. Notice that that's about lined with 5 there. So we could call that one of two things, and one is called the baseline pressure. Especially if you're taking the NBRC exam, they may refer to it as that. But you would know it really better as PEEP. They may not call it PEEP, they may call it the baseline pressure. Sometimes on the NBRC exam, they may ask you to label certain parts of a graph, and so that's important. Now, I'm aware that not all of you are preparing for the exam, and kudos to you for watching this, because you may be a respiratory therapist and you're just trying to up your game. And trust me, it's good for both reasons, but I do help people prepare for the exam, so I can't help but add that in there as well. What does the NBRC think about this? All right, and then as we go along here, we see that the pressure is going to start to rise on a certain breath like this, and then it's going to hit this point right here. And this point has a name. This is going to be called peak pressure. And so we have peak pressure there. And if you want to know what the peak pressure is, all we would do is take this little point right here and we would follow it to the best of our ability over to the left. And you'd see this is a peak pressure of about 25 centimeters of water pressure. And so that's what you can tell from that. Okay. All right. And now, then moving my graph here a little bit. Okay, now the other thing that we can look at is that we can look at this section right here. But we also have this little point right here and this little flat here. Now that is what's called the plateau pressure. And the reason why we won't always see that is because we would have to have a plateau time involved. We'd have to have what's called an inspiratory pause. And that's what have the ventilator give us the plateau pressure. That's why I said originally, if you're walking into a patient's room, you probably don't have an inspiratory pause. It's kind of uncommon these days to use that. It increases mean airway pressure, so we're worried about that. But if you do see that, then that's because you've dialed in an inspiratory pause. And sometimes we'll dial in that pause just for a few seconds so that we can see what their plateau pressure is, and then we can analyze this graphic for that. But that's what's important there. All right, and then this is pressure, and of course pressure versus time. There's another thing I want to show you is that I can look at something called mean airway pressure, which we'll talk a lot about. And it's basically the average pressure that is encapsulated under this whole thing. Now, you don't have to know that, but look, if you have peak pressure right here, and you have plateau pressure right here, but the pressure started off down here, then somewhere in the middle is going to be the average. The average is going to be somewhere here. And that's really what mean airway pressure is. But I just wanted you to know that everything under that graph is what comprises mean airway pressure. All right, so that's the basic anatomy of that graph. Let's take a peek at a couple of problems that could happen. One of the problems is that the pressure waveform can come up like this, and then it might dip down and then go up here and come to a peak and then come back down. What you want to pay attention to here is that there's a little bump in the mountain. I call that just a little bit of a bump there. That bump is really not supposed to be there. What's happening to the patient is that the pressure is beginning to build as the breath is delivered, but they are taking their own breath. And if they're taking in the breath faster than the breath or the flow that's being given to them, then the pressure will cause a slight deflection. The ventilator doesn't know what to think about that. It's just that the pressure is being taken away from the person trying to take a quick, deep breath. And so what it should indicate to us is that we have inadequate flow. And so this is going to be a flow problem. Okay, so this is about flow, and you would increase the flow. Now, isn't it interesting? We're looking at a pressure waveform, and we've come to the conclusion that we have a flow problem. You might think that we can only get flow problems by looking at the flow time graphic. We would have a problem there as well. We'll look at that in just a little bit. But that bump in the mountain is not supposed to be there. Really what you're supposed to see, and again, let me just mention this for the respiratory exam, is you're supposed to see what's called a smooth rise in pressure. And so we're interested in a smooth rise. If there's anything about this part right here that is not smooth, and it isn't because there's a bump there, then you know you have a bit of a problem. And so that's just one thing that we can look at there. All right, and now we can look at other pressure problems, but we like to look at pressure problems relative to other things. That's one of the main things. If you can just, basically, if you can just label the parts of that, as we talked about peak pressure and plateau pressure and PEEP, and then what represents mean airway pressure. You'll do really well on the exam, and that's the understanding behind a pressure waveform. Okay, let's take a peek now and move on to the flow. A flow time waveform. Flow time waveform is very interesting. Let's look at some of the key parts here. What we're really tracking here is not the volume that is put into the patient. That's tidal volume, and we'll talk about that in a little bit. What we're talking about is the speed at which the air is being injected into the lungs. Typically on a ventilator, what we'll adjust is a peak flow. So if we put the peak flow at, say, 50 liters per minute, that doesn't mean that's the speed that the ventilator is using. The speed's going to vary as it starts the breath and ends the breath. It's going to rise and then it's going to fall. But we're going to tell the ventilator not to exceed a peak flow of a certain amount, like 50 centimeters of water, 50 liters per minute, that kind of thing. So that's really what's happening in this graph. So let's take a closer peek. So the first thing you'll see here is that the ventilator breath is going to, of course, the ventilator breath is going to go up like this, and it's going to reach a certain peak flow. Now, in this case, it looks like we have a peak flow set at around 50, and it's not done at that point. It's come up to the peak flow, but it's still going to push in air. Why? Because its goal is to deliver a tidal volume. And so it's going to now it's not going to go above 50 liters per minute, but it's going to keep delivering the air until it gets to this point right here. And we have a label for that point. That's where tidal volume is accomplished. And this point right here is where we have the peak flow. And you can just go to the side here and tell that that's about 50. Once the tidal volume is accomplished, now we're done. Now the ventilator is going to turn off. And that just means all of a sudden the flow is going to go right back down to 0. And that's right here. And then there's a bottom side of the graph we have to pay attention to. This next side of the graph is flow that the ventilator is detecting, but it's going in reverse. And the flow is coming out of the patient. This is the exhalation. And so this whole thing right here is going to be inhalation. I'll put INH. But this right here is exhalation. And so notice that the patient is going to exhale, exhale, exhale until it gets to this point right here. And then they have completely let the breath out. And then a little bit of time goes by, and then the next breath begins. So that's the proper anatomy of a flow time ventilator graphic. That's what you should see. But now let's take a peek at some things that can go wrong. So as we said just now, we have a breath that starts, for instance, so it might go up to say the peak flow. Let's just say it's at 40, and then it might come over and delivering the tidal volume. Then it's going to come back down, and the ventilator is now done delivering the breath. Now all of the air is in the patient. Now the flow is going to reverse because the patient's going to start blowing out. And now watch what happens. Something that can go wrong. So the patient blows out like this, this, and then before it gets to that baseline, look what happens. Another breath takes off like this, and it reaches tidal volume and it comes back down. And then the patient blows out, blows out, blows out. And then before they can blow out all the way, another breath begins. So you can see the problem here. The problem is that the patient's exhalation is not returning to baseline. And that means that there's air still left in them when they are getting the next breath. And so what's the outcome? Well, you might know this outcome as auto-peep. And it has several names. You would also know it as causing air trapping. So air trapping is a problem. Another name is intrinsic PEEP. There's some names for that. We don't like that. Now, how do we fix that? If you want to know how to fix that, then once again, we're going to go right back to our friend, which is flow. And so we would probably increase the flow. If we increase the flow, look what's going to happen. If I increase the flow and make the breath in go faster, that is going to decrease inspiratory time. And if I were to decrease the inspiratory time but keep the rate the same, then what I'm going to have is a resultant increase in expiratory time. And that's what we want. We want to buy ourselves more time, so there's time for this little graphic to go all the way up to the baseline, all the way up to the baseline before the next breath begins. And that's what we're looking for. And so that's auto-peep, air trapping, so we watch for that. watch that very closely. All right, let me show you another one here if I can. Here's another thing that can go on with flow if you watch it very carefully. So as usual, you have the start of a breath, goes up, and then it finishes delivering the tidal volume, and then it comes down like that. And then now we have to look at the bottom side of the graphic. The bottom side of the graphic, the patient will start to blow out, and then it comes up this way, and then this little stair step will start happening. And maybe they get to blow all the way out before the next breath begins, but we have a slight problem here. This is supposed to be smooth, and it's not. And some people call that a sawtooth. Well, there's several potential problems that could be. It could be that you have water in the circuit, and that's probably just condensate, right? So you could have water in the circuit. The other problem is that it could be secretions in the patient's airway. And the third problem is that they could be constricted. In other words, they have constricted airways. And so we'll look at that kind of carefully. I want to just tell you a quick cheat. You can kind of look at those graphics and tell which one of those it is by looking at it this way. And so let me just kind of let me just come down here and kind of show you that. So if I have one of them that looks like this, okay, so it comes up, gives the breath, comes down, and then if it's water in this circuit, what's going to happen is the stairs are going to be kind of big. And so that would be more likely water sloshing around in the circuit, and you just need to drain the circuit. Maybe your reservoirs are full in the circuit. But if it's going to be secretions, it's going to look something, let me change that a little bit. It's going to look something more like this. It's going to be not big stair step, but it's going to be smaller stair steps like this. And so that would be more like secretions. And then my favorite one is bronchoconstriction. It's going to look like this. It's kind of jagged like that. So if it's really fine, then that's more likely that it's airway constriction. All right, and so what you do about it just depends on what it is. Obviously, if there's water in the circuit, then the answer, of course, is drain the circuit, naturally. If there's secretions in the patient's airway, then you're going to want to suction the patient. And then if there's constriction, then you want to give a bronchodilator. And so that's how you know what to do. But in real life, we're not able to analyze that graphic to that detail. Sometimes it's obvious, sometimes it isn't. So you're just going to do all these things very quickly. You're going to look at that stair step, that sawtooth, and you're just going to make sure there's no condensate in the circuit. That's very fast. You have to do that all the time anyway. And then, of course, you might suction the patient if you haven't been suctioning lately, and so you'll make sure that's there. And then you'll also listen to breath sounds. If you heard wheezing, you would know that was constriction. So it's not just the graphic you're looking at, but it's also the patient's condition, your objective and subjective information as well to a degree. All right, and so that is flow time, a very powerful graphic that you can look at. And then, of course, the last one is volume time, and this one's pretty simple. In fact, I'll just kind of show this one to you right here. Already drawn out. So this just looks kind of like a triangle. Now, but this one right here has a problem, because let me show you what it's supposed to look like in this case. All right, so a normal one is going to look like this. It's going to go up, and then it's going to go down. And then time goes by, and then the volume will go up, and then it'll go down. But that's not what this one is doing. So we're looking simultaneously at the problem. Notice here that it is going up. That's good. But when it comes down, it doesn't come down all the way. And then it creates what's called a new baseline. That's a problem. And what's happening there? Well, this would be the result of basically a leak. Now, that may sound like a simple problem, but it depends on where the leak is. So most commonly, the leak is going to be found probably in your circuit connections. Maybe the circuit's not connected to the ET tube perfectly, it's a little bit off. Or maybe one of the connections to the ventilator, it's not connected perfectly. And so some of the gas is coming out of the patient, it's all coming out of the patient, but it's just not making it back to the ventilator to be counted. So in that case, it's just a problem with the ventilator. The patient's fine. They're getting their breath and they're exhaling all of it. But another problem is that what if the leak is inside the patient? So for instance, you could have an ET tube cuff that is not inflated all the way, or maybe it's ruptured. And so with every breath, the ventilator is delivering a tidal volume of, say, 700, but some of it is coming past the ET tube and then just back out, and then it's never going back to the ventilator. So that'd be a clue to watch for. Of course, you'd look for other evidence. You check the cuff pressure. You might even hear a gurgling sound at the top of inspiration. You might even see foamy bubbles that are coming out all the time, would indicate to you that there's some air passage coming back around the cuff. And so you could look at that. And then I won't get into this super deeply, but if you have chest tubes in because somebody has a perforated lung, it's possible that you have a hole in your lungs. And with each ventilator breath, it's going into the lung tissue, but it's going out the hole. And then the chest tube drainage system is sucking that tidal volume out. And for that reason, it also would not return back to the ventilator. And so you have to determine which is the source of the leak. Hopefully it's just a circuit connection, but that's what you can tell from there. And so that's the basics of ventilator graphics. When we talk about pressure versus time, we look at flow versus time, and then also volume versus time. The most powerful of those two are the flow time and the pressure time. You'll look at those all the time. Now in part 2, we're going to get a lot more into the nitty-gritty and start comparing not to time, but pressure to volume, or pressure to flow, or flow to volume. Those are a lot more powerful in terms of understanding what's going on with the patient. So I hope that's been helpful. This is just part 1. Stay tuned for part 2. Be sure to subscribe so you get notified as well that it's coming out. And there's that and lots of other great videos. So we'll see you then.